Thank you guys for being here. My name is David Balcom. I work for the American Cancer Society, and I lead our digital platforms at the Society. We have got a really profound and amazing panel today. I'm glad that you're here. And what I want to do is first introduce our panelists, and then they're each, the four of them, going to give a brief talk, and then we're going to have some Q&A. And during the Q&A, we really invite you guys to participate and to get involved as well. So we're going to go ahead and get started. So I'm going to make a nod to my panelists, then I'm going to do some longer introductions. This is Joe TRIPPI from TRIPPI & Associates. To his left, we've got Claudia Pagliari from the University of Edinburgh, Eric Augustson from the National Cancer Institute, and Josh Nesbitt from Medic Mobile. So first up is going to be Joe TRIPPI. So Joe is the founder and president of TRIPPI & Associates, heralded on the cover of the New Republic as the man who reinvented campaigning. Joe has been at the forefront of political movement politics for nearly 30 years. Joe began his political career working on Edward Kennedy's presidential campaign in 1980 and has worked on numerous presidential, gubernatorial, Senate, and congressional campaigns ever since. And most recently, Joe was senior strategist and media consultant in Jerry Brown's successful run for California governor. TRIPPI & Associates also led the campaign's online strategy, raising nearly $3 million online, generating the most YouTube views of any gubernatorial candidate in the country. And in addition to his political work, Joe's consulted with a number of leading corporations, including Monster.com, including Toyota, Daimler Chrysler, ACS Americom, Corning, LabCorp, IBM, Lionsgate Films, Best Buy, Wave Systems, and Research in Motion. So please join me in welcoming Joe TRIPPI. Thank you.
Thank you. I wanted to talk, I'm very excited about what's happening with advocacy and mobile health advocacy in particular in the developing world. I mean, I really believe that mobile is capable of doing some amazing things in terms of both education and moving health forward in ways that will affect millions and millions of people in the population. I want to just talk briefly about, there's a big difference between mobile and how we got to mobile. All the other mediums, radio, television, were pretty much one-way mediums, and they took, the other thing that's important about this quick chart here is how long it took each of these mediums to penetrate populations. I mean, it took television decades in the United States to reach saturation, 80, 90%. Computers, it took forever to get 100% of the population in the states to have them, and then another round to get them connected to each other and connected to the internet and with information flow. That is totally different with mobile. Mobile is the fastest paced communications change in history. It is moving very, very quickly, and it allows, the last two, computers and the net, obviously allow both two-way communication, but also allow to organize things from the bottom up, not the top down. The other two, TV, radio, it's all been top down. The internet was like that for quite a while, but it's really empowering amazing things from the bottom up. And that opens up communities that have previously been isolated throughout the world. And also the important thing to note is in this rapid pickup of mobile, different places are lagging in these different technologies. Africa and Europe adopted SMS far more rapidly and mobile far more rapidly than the United States has. So in the developing world, many of these countries are jumping straight to mobile from paper. It's because they've got cell towers are being put up a lot faster than the internet or even TV towers. in other ways to communicate. I mean, it is jumping straight from paper, skipping all the other mediums to mobile information. In Nigeria, where we've done a lot of work, every single village has a cell phone. The entire village may share it, but everybody has access to mobile. They may not have access to electricity. They may literally be bicycling a power source to charge up the cell phone, but the village has a cell phone. It's a pretty amazing thing. That opens up some real possibilities already. A doctor in Guatemala City, for instance, can literally monitor or answer questions about a newborn in a rural part of the country now. And it's not by a landline. That's the other thing. I mean, the cell towers are beating landlines everywhere. And so there's ways to communicate now that reach people that we've never had any chance or opportunity to reach, and they can reach each other. So this infographic was released by the World Bank in October, and what it shows is that this rapid adoption I talked about, 75% of the world now has access to a mobile phone, again, including many of these villages that I've talked about. And that pace is rapidly increasing. Now, the interesting thing about it, though, is that that 75% had access to mobile phones. In 2003, 61% of the world was able to receive a mobile cell phone signal. So 75% of the world has phones, 61% had a signal. By 2010, that number's already gone up to 90%. So 90% of the world has access to a signal and can get it. And that means very, very few places that you cannot reach people with mobile and text. So that's a really important opportunity, particularly for mHealth, because these mobile phones and networks are giving everybody the opportunity to join together to solve problems. And there are already some amazing examples about this. People can, and I'll get into this specific example in a second. I just got to one slide too quickly. Public health information can now be spread into every community. In Nigeria, as an example, after the political campaign there in which mobile was used quite successfully, they started to realize that they could move messaging about mosquito nets and other things through text messaging to the communities that were being hit by them, and to help spread preventive information. Community members can report back conditions in communities in real time. Everything from a dead animal, and where there's clusters of dead pigs or dead chickens and things like this in some of these countries, can really perhaps start to give warning signals about potential epidemics or pandemics or disease breakouts. Patient follow-up, like I talked about with the doctor in Guatemala City. Care management for physicians and patients, and as I talked about, the epidemic and disease monitoring and tracking are all real possibilities now that we have this technology that's reaching that many people in the far reaches of isolated places that we haven't been able to communicate and exchange information before. The spotlight I wanted to put on just one example. Learning About Living program in Nigeria. This program, the youth in Nigeria, there's strong opposition culturally and otherwise to learning about their own sexual health. So learning about living allows young people to discreetly seek advice through SMS messaging. The service was launched in 2007. It's received already over 400,000 young people have requested help and information across it. They realized that AIDS was a serious problem with AIDS was that there were serious problems with HIV, adolescent pregnancies, abortions. I mean, there were clandestine abortions in the society. A lot of this came from a lack of awareness among young people about how to protect themselves. And it wasn't that they didn't want to protect themselves. They had no idea where to get the information, and wherever they went in their village or village elders or other problems, they were admonished to not get the information. Live operators were trained in sexual health education, and they answered the private text with text messages. The project, since this project has had such success in Nigeria, it's now being expanded in Senegal, and a team is working on deploying it in Morocco. This is just one example of some pretty simple, educational, and stuff that makes a huge difference in people's health. So the principles and challenges of mobile advocacy, I just want to go over them for a second with you. Two-way conversation is incredibly important. It's what empowers people to spread these messages. They become part of the ability to move information like we're talking about, and even just to move information that the program exists, and that if you want to ask questions about your sexual health, here's the text message, the message that can do it. So it's about engaging people in a two-way conversation that we've not been able to have with just a public service, a message on television or on state television or on the radio, which has obviously been important ways to move health information in the past, but there's no way for people to engage, either report health information or to spread educational information. The second thing that's really important is to reach your targets where they communicate. It makes no sense to have gone through all the work of having an Android app that lets people report that they're sick if no one in that country is downloading Android apps. I mean, it's a great app, it's wonderful, but you have to communicate the way people are communicating. That may be a situation where text, just simple SMS text messaging may be more important. The other thing is, in creating a movement on health or health-related movement, it's important, again, engagement is everything. It's to empower people. One of the things that's happening in this is that a great, I think he's a conservative blogger, but he wrote the book, Glenn Reynolds wrote a book called Army of Davids, and what he was saying is that the internet and mobile have created the ability for people to organize armies of Davids to take on Goliath, be it a disease, a government, a corporation that isn't doing, it's not a good corporate citizen, but that's what you're seeing in the world today. I mean, what you're seeing with the Arab Spring, for instance. In a world where armies of Davids are able to self-organize on the internet or across mobile networks, you don't want to be Goliath. You want the disease or the problem to be a Goliath. What do we want to be as practitioners, or the folks handing out the slingshots, empowering those people and giving them the tools to make a big difference against the disease, to report, even like, a global app where people would simply start reporting what they're eating might give us lots of insights into what diseases come from that, and and empowers them to make a difference and collect that data. And then the last thing in engaging and empowering people to create that kind of movement is make sure that you're finding your targets. Again, now there's all kinds of strategies that are available today. For instance, in Africa, working with the mobile phone providers, the system, they may know the age of and the gender of somebody's paying those bills. And somebody bought that phone somewhere, and they keep a lot of data. Meshing that with government, you can find out where the women between 18 and 25 are that you're trying to reach with messaging about about the sexual health or something like that. And so you can really reach the right audience pretty effectively. And we saw this, by the way, in the Obama campaign in 2012, the notion of meshing data, big data in their case, with technology. And this is possible. We've done it in Africa, working with the telcos and the mobile telephone companies and government and NGOs. It's a pretty effective thing. And I'm just going to, I think, I don't know how much time I've been taking. I just wanted to run through some very quick examples of how in politics, what I'm finding is I think politics sometimes out of necessity breaks down the barriers or innovates, and then health, I think, tends to be the next thing right behind it because of the similar necessities. In Africa, we've had a lot of success with mobile, and one of the ones I do is in Nigeria. I think it was the 2005 election. Obasanjo, the then president, wanted to run for re-election, even though the Constitution said he could only serve 2 terms. In other words, he wanted to unconstitutionally run for a 3rd term. We started a text messaging campaign throughout Nigeria in which we asked people to text that they held the torch of democracy in their hands, pass the torch on, don't drop, don't let it be extinguished, pass the torch of democracy, and let's have a real election where Obasanjo doesn't run for a 3rd term. That torch, that cell phone was the torch. It literally lit up across the country. Millions of people text messaged that messaging. And this, by the way, is what triggered when Obasanjo didn't run, had the first transfer of peaceful transfer of power through an election that year. And after that, the government started to look at, that's what gave them the idea. You mean we could text message that people in this village should start getting mosquito tents because we were seeing incidents. So that's literally what started that kind of insight there. And in the MDC in Zimbabwe, Robert Mugabe was and still is president, but you may have heard that he lost his election for president. He did, largely because of Zimbabwean women who carried that flip cam in the far corner over there, carried them into the country and literally filmed the atrocities that were happening and put them on the internet and then spread messages about them through text messaging. The other thing they did was they took pictures. In Zimbabwe, the poll results are put out on the hut where the polling place was. They put the results on the hut outside and then take the box and ship it to the Capitol. Well, when they put the polling results on the hut, the women took the pictures of them with a flip cam, then sent them through their cell phones or laptops some of them had. And when you added all those huts up, Mugabe lost. What usually happened was he'd lose or he'd win, but no one knew that because all they knew was what the hut was and what the votes was, where their hut was, and not where it was across the country. They would take all the boxes to Harare where they would be counted, and oops, we would lose a bunch and Mugabe would win. Well, they literally put these up on the internet, and international observers could count the votes in every polling place, and it showed within minutes of the polls closing that Mugabe had lost. 30 days of counting in Harare later, Mugabe held a press conference and said he had lost. Only he hadn't lost by enough, so there would have to be another election. All this is by a crazy way of explaining to you that there's a unity government now in Zimbabwe between Mugabe and my guy, the MDC's guy, Morgan Shangarai. that was forced by the international community as the way to solve this problem. But my point again is, even in a place like Zimbabwe with very little internet penetration, they were able to change the politics of the country. And now what's going to follow, I think, over time behind that are a lot of the efforts of people in this room and others to use these technologies in ways that are very powerful and empower people to change their lives, and they're willing and ready to do it. I think with that I'll stop and answer any of your questions later on, so others we have more time for Q&A.
Joe, thank you. So I'm going to introduce our next panelist, Dr. Claudia Pagliari. We've also had some folks come in, so I also just want to reiterate what it is we're doing here. We're talking about the role of mobile health in cancer control for underserved populations from a number of different, I think, really interesting points of view from these panelists. When we've gone through each of the presentations, we're going to have a Q&A with myself and the panelists and include questions from you as well. So please get those questions ready. And we're going to save a few minutes to the end, right before the end of the panel as well, and we're going to ask something of you to take home and then to do as well. So stick around, please. Okay, so I'd like to introduce Dr. Claudia Pagliari, who is the director of the Interdisciplinary Research Network in eHealth and Health Informatics at the University of Edinburgh, Scotland. Dr. Pagliari is a senior researcher, educator, and consultant in health informatics, as we just said, health technology assessment. Originally trained as a psychologist, she's been engaged in the study and evaluation of health innovations for over 15 years. Her research uses interdisciplinary methods to explore issues around the design, implementation, ethical use, and impacts of e-health technologies, including electronic health records, telehealth services, mHealth tools, and online interventions. She leads the Interdisciplinary Research Network and the Master's Program at the University of Edinburgh, and she serves on several advisory panels in the UK area as well. Dr. Pagliari?
Thank you very much. I'll just sit here since we have a relatively small group. Thank you so much for coming. I'm going to speak to you today about mHealth and cancer. This session, as you know, has been sponsored by the American Cancer Society, and that seems appropriate. I'm going to start with some things you know. Cancer, well, maybe you don't know. Cancer is a global phenomenon. It doesn't respect geographic boundaries, and it's increasing worldwide. And the same goes for mobile ICT in much the same way. So how well are we linking the two? I've asked this question to myself, is cancer the Cinderella of the mHealth world? In preparing for this talk, I did a number of web searches, had a look around the app stores, and it became quite clear to me that in comparison with other areas like long-term condition management, cancer is fairly undercharted. Much of the attention has been traditionally, although things are changing now, on supporting professionals with sources of expertise, clinical decision-making tools, that sort of thing for cancer. Which led me to ask, well, what's the problem here? Well, one thing is that there's one big distractor out there. This is the slide you're not supposed to show at an mHealth summit. So whenever you do a Google search or something similar under mobile phone and cancer, you get hit immediately by pages and pages of do mobiles cause cancer? And this is a very equivocal and highly politicized topic just now. And I think it would be irresponsible of us not to consider it. But for the present purposes, this is a distraction. The second problem is mHealth is an extremely complex area. We've heard other speakers talk about the mHealth ecosystem. Well, in fact, there are multiple ecosystems operating here, all of which are complex, and they interact with one another. And this makes it very difficult to chart the area. It's been very poorly mapped. And the players in this field are expanding on a daily basis. And so are the apps. Thirdly, cancer is itself an extremely complex condition. There are many different types of cancer, all with different types of etiologies. Similarly, the context in which cancer occurs and people with cancer cope with it are very different. The objectives of all the different interventions for cancer are also very wide-ranging, and the kinds of people that have cancer are different even if they have the same cancer. And this demands different sorts of approaches. And I'm not quite sure whether we're really fully aware of the variability to tackle that effectively. Now, this is an enormous area, and there's great potential in mHealth in many aspects of research and other fields. And throughout the cancer lifetime. But I thought it would be helpful to focus down on one area, the cancer trajectory towards the end of life, which really gives you an indication of a small area of activity which itself is highly complex. And I also want to talk about the patient perspective, not the clinician perspective on this, just for now. Many of you may be familiar with these different models of the trajectories of life-limiting disease, and they've been charted and used in many publications. We see at the bottom the trajectory for cancer, which typically is a condition where people are fairly well for some time and then drop off a cliff. Now, this is basically showing you the physical trajectory of cancer. But cancer is a lot more complicated than that. The experience of cancer is very, very different. And researchers, including colleagues in the palliative care group at the University of Edinburgh, have charted the different trajectories that patients go through. Physical, we have here in the blue line. It's also clear from qualitative studies, of which there have been many in this field, that people experience a social decline when they become ill with cancer. They may become preoccupied with their condition. They may withdraw from their normal activities. But more importantly, other people may withdraw from them. And this puts a great deal of pressure, and it's similar for other illnesses. Embarrassment, fear of invading someone's space, these sorts of issues are important. But critically, there are also enormous psychological and emotional swings that happen when you have cancer. And these are typically marked by four main areas of transition. Firstly, when you get your diagnosis of cancer, it's like being hit with a 10-ton truck. Very emotionally draining. Secondly, after a period of treatment, possibly in hospital, possibly surgery or some other method, you return home and you've got to adjust. Okay? Thirdly, where the disease recurs, which it does in many people. And finally, when it becomes clear that the patient is terminal, is going to die. Now, I want to point out this is for patients who die. 50% of patients with cancer live, and there's an enormous survivorship agenda here, which we do need to pay attention to, but obviously people die as well. So these are some of the issues then that I've mentioned that are just as important as your physical decline. And I wanted to ask, well, how can mHealth help? Well, let's actually go back one stage here. And the reason I've put this in is because preventive health for cancer is probably the most well-researched area. The reason for that being that we have a wonderful history of public health research and health psychology research, which has developed many tailored behavioral interventions for improving people's healthful behaviors. There's also, and this overlaps with the advocacy talk, a great deal of potential for mHealth to raise public awareness of health, disease, and the need for screening, for example. This is complicated in mHealth because it's not a question of mass campaigns and billboards and TV advertising. You're trying to reach people as individuals, and they may not want to get those messages on their phone. So should we be thinking about novel methods of addressing this? possibly by working with the network providers who, as we were hearing, have knowledge about the demographics of the populations and possibly those who might need the particular types of information, to perhaps have a mass customization, as I've heard another speaker describe it, of messages to particular groups. And how would we finance that? Are there new ways of creating reciprocal agreements between network providers so that the consumer gets charged slightly less if they agree to get some health messages? And that might work well with underserved populations. It's an unmarked space very much. Similarly, in prevention, there's been quite a lot of success in the use of screening reminders for cancer prevention. And this is, I have a slide about that in a moment. But we also have potential for crowdsourcing information that could help people to prevent cancer from occurring. One I came across recently was an app for people living in an area with high radon gas levels. And they were being encouraged to test the radon gas levels and send messages back. There's been similar approaches used in Japan following the earthquake and the leakage of radiation. Some quite innovative work there to map what's going on. These are some. I'm flagging a recent systematic review by my colleague Robin Whittaker sitting there as an example of an area which has been well charted, anti-smoking prevention. But just looking down at the bottom right-hand side, I came across this app a couple of days ago, and I like it. This is an example of how we can integrate traditional mass education with mobile. This is a program which shows in the UK called Embarrassing Illnesses. Now, it's very, very popular, mostly because people want to have a look at other people's sort of bits and see what's gone wrong with them. Now, fortunately, because of that, a lot of young people have tuned into it, and they started asking questions. Initially, they went to the website. But the developer, the company has now set up this educational app now, so people can discreetly go and find out about I think they call it, you can check your breasts or your balls or whatever. They've put it in young people's terms. So a mass media intervention and a direct intervention are working well together. So there's a lot of scope there. But moving back to the cancer itself, as I said, the diagnosis is a real shocker for people. And whilst there are many needs that one will have at that time, the overwhelming need is for information. What is this? How can it be treated? What's my prognosis? What are the alternative methods? Am I being denied the best possible care? These sorts of questions. And there's been fortunately a growth in mobile-based access to traditional medical information that has been made more easy to understand via patient advocacy groups. Similarly, patients are now going online to get social support from one another. Agencies like groups such as Patients Like Me encourage patients to look for other people like them with their condition. You can go on, you can find out what other people have experienced. And those groups are crowdsourcing medical knowledge themselves and crowdsourcing helpful tips about how to cope with things as well. In some cases, they've even generated new research and new data. They're sharing their electronic records. But mainly it's about information here. In 2011, mobile visits to www.cancer.gov nearly doubled, and that forced them to rethink this area. Here's an app on the bottom right called Beyond the Shock I came across for new people who've been newly diagnosed with breast cancer, very much written from the user base. So one's a professional resource, one's from the user base. Moving on to the next phase, when you've got cancer, you're dealing with it, you may have a recurrence. Again, many social, emotional, and health needs. People are increasingly using mobile to access their health record. This is a growing trend. Self-monitoring tools are allowing us to using mobile to send readings of our physical and psychological symptoms to our health providers. Medication reminders are increasingly important. cancer is complex, medication regimes are very complex, and in an era of personalized medicine, that is set to increase even more. You may reschedule your medication fairly frequently. How are people going to make sense of that? Clever apps for allowing people to remember their medication and use it appropriately are going to be very useful. And similarly, it's very important at this phase to recognize the role of the carer. Now, this trajectory here that you see is almost perfectly mapped for the patient and their carer. Somebody looking, if you're looking after one with cancer, you go through exactly the same peaks and troughs as they do. And in some cases, it can become even harder. It's emotional, it's physical. You might have to give up your job. There are economic pressures. So I think that's very important to bear that in mind. Social networks for carers are appearing, for example, that allow people to feel that they're part of a community, and they use mobile apps. Here's some slides just to show you some of that, but I'll draw your attention to a couple here. Down in the bottom right is an interesting area that's picked up for pediatric cancer recently. Young people with cancer, there's been a community developing games for young people with cancer, not just to entertain them and make them feel part of a group, although those are both important things, but also with the theory that by visualizing an attack on a cancer cell, you somehow can overcome it. Now, this is very sort of tentative. It's not completely without any theoretical basis, and it's certainly one to watch. At the end of life, there are very many practical needs we're well aware of, but there are also existential or spiritual needs that people haven't really talked about until fairly recently. When you're going to die, or your loved one's going to die, you start asking those big questions that maybe you've buried a long time because you didn't want to deal with them, or you felt that you were sort of too intellectual to engage with your religious roots. Suddenly things change, and people are left in sometimes in quite a serious crisis situation. And palliative care nurses have recognized this for a long time. But increasingly we can try and address that using eHealth and mHealth. It's very much an underdeveloped area, but I think it's very important to think about. And there are also issues around end-of-life planning using mobile phones so that you can keep in touch, keep it on top. Here are some end-of-life apps that are out there, and podcasts as well that you can download. Some are around dealing with death and dying. They help people to resolve the problems that they have maybe in their family relations, deal with regret and anxiety, deal with fear, and look to the future. And again, these are not well evaluated, but they're coming. There are not many of them. Here's one on the top right called Grief Support, and that's an app for people who have lost someone, and they support each other using social networks, and they also can deliver helpful messages. So obviously there's a whole load more to discuss there than I've had time to do. This is a big area, but I hope that's given some food for thought, and I just want to pick up on some challenges in this area. One is that we just don't really understand the users well enough yet. We need to do a lot more to understand the users and what makes them different. It's not simply a question of saying this app will work for breast cancer, or this app will work for testicular cancer at that stage. It's very important to think more thoroughly. What about the type of cancer? How treatable it is? Is it? What's the likely prognosis and timescale? How disabled does it make the person? For example, I was in a meeting with a group from Norway last week who were developing a pain assessment app using an iPad, and they found that people couldn't hold it because it was just too heavy for some people in hospital. So thinking about these issues is quite important. What's their stage of illness? We have different needs for information at different stages of illness. Some things may be very practical, some things may be much more emotional, some things may have to do with social relationships and feeling supported. The context is very important too, the big one being whether you're in a high or low income country, but within your own country, are you insured or underinsured? That's a big one. How do we deal with that? Can mobile maybe help to overcome some of those disparities? And critically, is it an older or a younger person? Plenty of older people use smartphones and other technologies, but the sorts of things you might want to do with them are different. So game-based approaches may be more appropriate for young people, for example. And critically, are people living alone or with someone? A lot of these models assume that when you're dying of cancer, you have a loved one looking after you. You're at home. You get on with your family. For a lot of people, that's just not true. The number of single-person households is increasing, and in some parts of the world, in Northern Europe, are reaching 50% or more. So what happens when you're dying with cancer alone? How do you deal with that? Maybe then you need to crowdsource that support. Then you need that push support and pull support using mobile. Worth thinking about. And finally, I'd just like to mention the importance of personality. Nobody really talks about this, but it's important. Some people are very private people. They don't want everyone having a window into their lives. Whether other people are very sociable, will reach out, will seek support. We have to respect that. We have to respect that not everyone's going to want the same thing. And similarly, people are more or less trusting. Different people have different degrees to which they can cope with things like bad news or tasks that may be complicated. And their religious beliefs may vary a lot. So that's something to take into account. So, I just wanted to flag that. And other issues that, and this is, again, a theme in the conference, and I think it's a very important theme, is that we need to build the evidence base. There are a gazillion apps. The apposphere is mushrooming. Now, how many of those apps have been evaluated? I would say the tiniest little fraction. No one really knows whether they do any good. They might think they look good. There might be some good reason for them having been developed. But nobody really knows whether they make a difference. And I think this is very important. We're in a wild west here of apps. Loads of stuff is being developed. No one is quite sure if it's helpful or, more importantly, if it's harmful. And critically, whether it's worth the money. A lot of this stuff, though, it is actually free. And we face a challenge here, I think, between the need to innovate, the need to develop new stuff and serve new populations, against the need to build that evidence base. And I'm very keen to find joint approaches where we can overcome that culture clash between the tech community and the academic community, between evidence-based medicine and needs-based provision. And we need to be smarter about how we're doing these things. We don't always need the most expensive gizmos to make a difference. SMS is the #1 transformative mHealth technology in a lot of the world. We should make more of it. But we also need to think ahead. There are opportunities to harness Web 2.0 and increasingly 3.0 to improve the tailorability of our interventions and their reach. We need to partner strategically for impact where it's needed. I mentioned the idea about working with the network providers to target messages that are appropriate to particularly underserved groups, for example. And finally, I just want to say we need to be very careful about patient safety and, critically, privacy. Thank you.
Thank you very much. Thanks. Next up, we've got Dr. Eric Augustson. Dr. Augustson has a PhD in clinical psychology and an MPH with a focus in epidemiology. Since 2001, he's worked at the National Cancer Institute in the Tobacco Control Research Branch, where he's a program director and a behavioral scientist with more than 60 scientific publications. Among a wide variety of research, training, and dissemination activities, Dr. Augustson co-leads projects related to the use of emerging technologies as a way to improve reach and engagement of smoking cessation and interventions for other health behaviors. These include the Smokefree.gov initiatives, eHealth and mHealth cessation resources for general adults, women, teens, and Spanish-speaking smokers, and he also serves as the Department of Health and Human Services lead for cessation mHealth projects, including Smokefree TXT. Please join us in welcoming Dr. Eric Augustson.
And I'm going to go ahead and stand. This is the kind of thing we should probably never announce at a conference, but there's a growing body of literature that a sedentary lifestyle is highly associated with a host of negative outcomes. So you folks, in politeness, will continue to experience those outcomes, whereas I will avoid them by standing. So what I want to talk to you about today is specifically this idea of how can we use mHealth platforms as a means to deliver interventions. So the focus of what I want to talk about is really very much intervention-based, and I'm going to do a couple of different things here today. But, well, first of all, I want to start by acknowledging the team of people who I work with. I work with a very talented group of young people. Underline the young. That turns out to be crucial if you're in the mHealth space. For those of you who remember a lot of the technology Joe was talking about, you need to hire people who don't remember that technology. And I want to give a couple of shout-outs here. One is Shawnee Taylor, who is the project manager for the scope of the Smokefree.gov project, which you'll see in a moment is really quite large. I also want to give a shout-out to Amy Sanders, who is the leader of Smokefree TXT, which is one of the things I'll be focusing on today. And then I also want to acknowledge two very talented groups of subcontractors who are the people who have provided the platform from which we've been able to deliver this intervention. These include Infield Health, who were the first group we worked with, really helped us build that up, and Mobile Commons, who are the second group that we're working with right now within the Smokefree TXT area as we continue to advance and expand our resources. So very quickly, what I'm going to do is talk about the potential of mHealth specifically as it's associated with interventions. I'm going to give you a little bit of background about how smoking is bad. And then I'm going to provide a brief overview of Smokefree.gov, focus on Smokefree TXT, and provide two case examples, one from our domestic program and one from a project we're working on within China. So there's a classic formula within public health, which is reach times effectiveness equals impact. Within the work that my team and I have been doing over almost the last 10 years now, we have more and more been shifting how we understand that formula to be reach times engagement equals the impact. We spend a lot of time at conferences like this one here and other ones kind of being bedazzled by the reach that these technologies give us. And that reach is, in fact, kind of, just like deer in the headlights. When we start talking about 6 billion cell phone contracts in the world, suddenly our eyes get huge. However, what we often overlook is the importance of using these technologies in very specific ways to increase engagement in that technology. And then again, in the case of the work that I do and my team do, we're talking about increasing engagement as it's associated with a specific health behavior change intervention. How can we use the technology to increase people's engagement with the treatment? So there are a number of advantages that mHealth potentially has. So first of these increases access to the intervention. So a lot of the classic obstacles that we have, I've got 2 kids, I don't have a car, how in the world would I get in to see the clinic? These become removed with mHealth. We also have decreased barriers to participation. You can participate whenever you want. You don't have to come see me during my office hours. There's also, and this is a concept that we are just now really starting to think through, the next couple ideas here. The first of this is that it decreases the space and the time between the therapist and the user. Or another way to think about that is between the intervention that's delivered and the client or the user engaging in the behavior we're trying to modify. So in the traditional therapeutic session, you come and see me for 50 minutes, and then you go away and you spend a week or 2 weeks out in the real world where I become further and further away from you. Mobile health allows us to shrink that distance, the distance between you and me, as we try to affect behavior change. The other thing that we're doing is we are seamlessly integrating that treatment into the real-world context of that user's daily existence. So again, in the classic therapeutic intervention, the problem is you and I will talk about things, but then when you go out into the real world, the context in which you have to actually do that intervention is very different than the context of sitting with me in my office. So again, mHealth allows us to bypass that. And then lastly, and this is something, again, that we're just now beginning to think about and trying to find ways to really capitalize, and that is that the interactive functionality of the kinds of resources we create can improve the dose. We can get people to do more of the treatment and thereby increase the dose. And we know this across many, many settings that increased dose is a fundamental means to increase the impact of a treatment. So here's just a few basic facts about smoking and health. Everybody in this room knows smoking is bad, but you may not really realize how bad or how bad on a global level. And so this is, some of this data is why smoking is an exemplar behavior for us to be trying to intercede with on an international level. So currently smoking is the #1 cause of preventable death in high-income countries, and in the United States accounts for about 20% of all deaths. However, what's not as well known is that by 2030, so in less than 20 years from now, tobacco-related diseases will be the leading cause of preventable death in low and middle income countries. And the burden of tobacco is shifting to those low and middle income countries such that 75% of the tobacco death burden is going to be carried by those countries. As the developed countries shift away from tobacco, the tobacco companies are marketing more in those countries, and the devastation of these diseases will make the Black Death look like nothing. So beginning in 2003 at NCI, we began to think about how can we use these emerging technologies as a way to effectively intervene with smoking on a much broader level. Initially, like I said, we were mostly captivated by the idea of expanding our reach. Over time, we've released a number of additional resources. In 2009, we developed resources specific to women, and this is where the National Cancer Institute and in a large part, we were one of the first groups within the government as a whole, really began to move into social media and the use of emerging technologies. 2011, we launched Smokefree Teen, and then most recently, we've launched a Spanish version of these resources. Over time, the smokefree.gov program has expanded to the point where it now includes 4 websites, numerous social media platforms, 3 mobile apps, 3 text messaging programs with 3 new ones on the horizon, so we've really expanded this quite a bit. What I want to spend the rest of my time with you today is focusing on smoke-free text. So this is one of the resources that we have, and currently it's the one that we are also trying to really find ways to tailor to underserved audiences, and also we are moving into an international space as well. So smoke-free text, I'm going to not give you a lot of detail about this in the interest of time, other than to note that this is a free service that's offered by the National Cancer Institute. Normal cell phone rates do apply, so our main target audience are individuals with unlimited text messaging plans. It provides 2 weeks of lead-in to a user-identified quit date, with messages increasing in frequency until you hit the quit date. They then increase in frequency a little more and then begin to taper off over a period about another 6 weeks or so. It is a bidirectional system, although there is no human being on the other side. It's all automated. And we also have assessment built into the evaluation itself, and this is part of the intervention, in that we assess mood, cravings, and smoking status, and depending on the answer the user gives us, we send back a message that includes an actionable behavioral strategy to try to address whatever the issue that's being assessed is. In the last year, we've had about 15,000 subscriptions to the program. Our breakdown is have a little more females involved than males. However, we're actually quite pleased with the distribution. We have a good participation by males, and for all you women in the audience, I would like to apologize on behalf of all men, because we tend to do a terrible job of engaging in health behavior interventions, largely because we rely on you to do it for us. But we are, in fact, getting some men involved in this program. About 80% of our individuals are daily smokers, so we are, in fact, effectively engaging our target audience, which are smokers who are more likely to be nicotine dependent. And this slide's actually really cool. It's, of course, impossible for you to interpret from where you're sitting in the audience. But what this slide fundamentally demonstrates here is, and this is based on user data, so this is not data from a clinical trial, and there's pros and cons to that. But the thing that we're really excited about, it's hard to tell from this, but what this slide is demonstrating is that our self-reported quit rates at 1 month, 3 months, and 6 months are all at about 13%. Which, for those of you who are not involved in tobacco, may not sound like a lot. However, the typical quit rate for individuals who do not engage in an effective treatment is less than 5%. So typically, depending on the trial, 2 to 3%. So the rates that we're getting are highly consistent with some of the rates that, for example, Robin Whitaker's team has revealed in some of their meta-analyses. And so we're very excited about this. This data is preliminary. There are problems with this data, but we have reason to be hopeful that this is showing us something that can be an effective tool within the United States. How am I doing on time? I've lost track of when I started, Doug. Okay, move along. Okay, so I'm going to move along real quickly. I just want to tell you about two things we've been doing in China. China, for those of you who don't know, has 300 million smokers. That's basically the equivalent to the entire population of the United States. And national surveys have demonstrated that only about 30% of their population are in fact aware of the dangers of smoking, and less than 15% of their current smokers want to quit. Of course, if you do the numbers, you realize that 15% of 300 million is still 50 million smokers. So there's a lot of good work to be done there. We have two projects going on in China right now. One is a collaboration with the China Ministry of Health and Nokia. This is a 2-arm randomized clinical trial that has 2 phases. Phase 1 involves 250,000 smokers. Phase 2 is more associated with the clinical intervention and involves 8,000 smokers. We also recently completed a pilot study with a city in China that was doing their annual quit smoking contest, and help them to develop a text messaging program for that. And what I want to provide real fast is some data from the Suzchou project, which again was a small pilot of 665 smokers who received a 4-week treatment. So a little bit about the baseline data. 60% of them were daily smokers. This was done in 2 cities. That's why there's 2 numbers there. Time to first cigarette, which is a marker of dependence, was actually fairly low. So we have a group who is not demonstrating high levels of nicotine dependence. However, what we found is that the 1-month quit rate in this contest was 38% overall. And it differed between the 2 groups. One group had a 57% quit rate, and the second group, which was a group that had higher nicotine dependence, had a 22% quit rate. But still, we're now seeing a quit rate of almost 40% in a population that has been traditionally extremely difficult to reach and engage, and in which there is fundamentally no organized infrastructure to support cessation. Part of this is that the main source of cigarettes within China is the government of China. They own the cigarette producing. And so there's very, very little infrastructure to actually support any kind of public health intervention. This slide basically shows that the feedback we got from the participants were that they liked the messages and they thought they were useful. Let me just close with some challenges that I think we need to consider when we're trying to reach underserved populations, whether those are domestically within the United States or on an international basis. The first of these, as has already been alluded to, is, well, the second one I'll jump to, which is multiple users may be using the same device. So there may only be one cell phone per family, one cell phone per village. The other thing, and this is certainly a challenge with many of the populations we try to engage within the United States, is the consistency of cell phone service. So they may buy a certain number of minutes, but when those minutes are gone, they don't renew that until the next month. And so we can get dropouts in terms of access. Fee structures continue to be a substantial challenge, in particular on an international basis, in that they can vary widely from country to country. How should we more effectively engage populations with low literacy? Text message involves reading. Now, some countries have extremely high literacy rates or high literacy rates for a language that most folks can understand, but that's certainly not true across all demographics, and so we have to think about how can we use this kind of technology to engage those audiences as well. And then lastly, just like there is no human being who is all things to every person, there's not going to be any intervention that provides all things to any user, any patient. So where do these kinds of interventions fit into the larger, in my case, tobacco control context? And I'll stop there. Thank you.
Great. And lastly, before Q&A, we've got Josh Nesbitt. Josh is the CEO of Medic Mobile, a nonprofit company using low-cost mobile technology to improve healthcare in challenging settings. Josh also created Hope Phones, a recycling campaign designed to engage millions of Americans in global health efforts. The Medic Mobile team has worked in 16 countries in East and West Africa, South Asia, North America, and South America, using mobile technologies to support a wide range of programs, from infectious disease surveillance in rural Malawi to emergency response after the 2010 earthquake in Haiti. Josh is an Ashoka Fellow, PopTech Social Innovation Fellow, Echoing Green Fellow, Rainier Arnhold Fellow, Strauss Scholar, and Haas Public Service Fellow. Josh was selected by DevEx as one of 40 under 40 leaders in international development, received the Truman Award for Innovation from the Society for International Development, and was recently named by Forbes as one of the world's top 30 social entrepreneurs. Please welcome Josh Nesbitt.
Okay, it's great to be here. I'm going to fly through this deck so that we at least have a minute or two to talk. So come up to me afterwards if you want clarification on things. But I'm going to start back in 2007 at a hospital in Malawi where I was doing HIV research. At this particular hospital, there was one doctor providing care for 250,000 people, and patients were walking or ox carting 100 miles to get to the hospital. And this is what I heard from the clinical staff. We don't know who needs emergency care. We can't monitor danger signs during high-risk pregnancies. We don't know who has tuberculosis unless they show up at the hospital's doorstep. And even if they do, this is the reality. This is actually a photo I took of the biggest government hospital in Kinshasa in DRC. But this is the reality. It's a black hole of information, and the hospital is basically where people go to die. So this was sort of a depressing start to this talk, but I became really increasingly optimistic when I met community health workers. And Dixon was the first CHW that I met, and I bicycled out 35 miles to his house in rural Malawi, and I had better cell coverage there than I did in Palo Alto. And it was really clear that this was the infrastructure we had to harness and had to use. So really, honestly, just put two and two together. I got back to the hospital with a backpack full of cell phones, sort of smiling at customs officers on the way. And we went through text message training with these CHWs. In 6 months, they were doing active case finding for tuberculosis, and they doubled enrollment in their program. They were saving thousands of hours of travel time using SMS instead of motorcycles for patient follow-up. And so we started to build a team to replicate these results and figure out how we could be more broadly useful in global health. So Medic Mobile, we're a team of software developers, designers, researchers, and project managers. And if you fast forward about 2 years, 2.5 years, I need to update that bio. We now work in 20 countries in East and West Africa, South Asia, Latin America, and actually the US. We have our first 2 randomized trials in the Bay Area starting in a week and a half. A lot of different work, and I want to talk about 2 specific projects really quickly. The first was focused on vaccination coverage in India. The baseline vaccination rate for childhood vaccinations was 60%. And we did some really simple things. We used a mobile application wielded by community health workers and facility-based staff to basically register every kid. Then we sent text message reminders to the mothers and grandmothers at the household level. And if the kids missed their appointment, an automated alert went to the community health worker looking after their village cluster. And we're now 14 months into this prospective trial. And at 6 months, the interim data showed a jump to 99% coverage for vaccinations. The majority of our users are community health workers. We're supporting frontline health workers in around 8,000 communities around the world. This is a female community health volunteer in rural Nepal. And you know, community health work is a funny thing here in the U.S. I talk about it everywhere else. I can walk into a village in rural Nepal and ask where the community health worker's house is, and they'll point me right to it. Pretty much there's one per community everywhere but the U.S., but I think it's a model that's coming here shortly. So community health workers are mostly our users, and what's finding its way into their hands are these heavily subsidized $10, dirt cheap, very ruggedized and durable and battery efficient mobile phones. And so basically this is our platform. This is what we had to figure out how to make use of. And we sort of had pushed text messaging to its limits and wanted to get a little bit more creative and complex, and stumbled upon the fact that you can run apps directly off of the SIM cards of basically any cell phone on the planet using SIM card applications. The challenge is you have to get a mobile operator to let you load your app on their SIM cards. And that was basically a non-starter. So like any good 20-somethings, we went to the internet, found some hackers in Prague that had figured out basically how to get this thing that you see sticking out of the cell phone and wrapping around the battery case is called a parallel SIM. And what it does is it's a little wafer that slides in underneath the existing SIM card, and that's a little microcontroller that runs our app platform. And this then presents the applications in the native phone menu of any phone, any GSM phone. So this is how we're shipping out community health worker apps and also prototyping family applications. And then when we do have data, and you can't really see it all that well here, but where we do have data, we're using distributed web applications to do the automated messaging, the data collection, and basic visualizations. So our platform's called Kujua. We also use a number of others. And then you can visit medicmobile.org/tools to find out more about this toolkit. But what it ends up looking like is a lot like this, basically. You have community-based users using simple cell phones. You have, in this case, an Android application serving as an SMS gateway, and then a distributed web application at a facility that's intermittently online. And I mention all of this because what's actually important is what we're able to do with the tools. And our job is to basically figure out which use cases need to be designed and scaled. And for us, you can boil down across about 100 projects now. You can boil down all of our use cases to 3 buckets. We help people access care and services they need. We help people stay in care. And we help improve the quality of care wherever it's being delivered. And what that looks like is, for access, infectious disease surveillance. It's about 20% of what we do globally right now. For adherence, programs that we know, where we know adherence in completing a program matters, like antenatal care, that's 9% of what we're trying to do. And for quality, stock and service monitoring as a use case at the community level has really started to scale. That's about 35% of what we're doing across all of our sites. And this maps, I think, importantly to cancer care. So if you look at the headlines for cancer care in sub-Saharan Africa, many cancers are related to infectious agents. Most cancers are diagnosed at late stage, and you have low survival rates. It's a pretty bleak picture. But instead, I want to focus on these first 2 and present them as really opportunities where we know we can do specific things. We can prevent, we can look at vaccine coverage, we can look at specific behaviors for sanitation, and not just a public awareness campaign, but actually taking it all the way to outcomes. I think that there's a real opportunity with mobile to actually track things like whether or not every kid in a school washed their hands that day. We're looking at that in rural Nepal, for example. For detecting early, raising awareness through campaigns, but also making sure that community health workers are engaged with screening processes, and then supporting palliative care. This sounds really simple. I'll tell a quick story. The very first text message that came into that hospital in Malawi was from a community health worker that had just visited a girl with stomach cancer, and she had run out of morphine. And so we got on a motorcycle with a bag of supplies, and that was one of our stops that day, about 60 kilometers out. Refilled their morphine, and a week later heard from that community health worker that she had passed away, that child had passed away, but that the mother and the family were supremely grateful that she was comfortable for that week. And that sort of responsiveness and connectedness just wasn't possible even 5 years ago. So the simple things matter, and the low-hanging fruit matters. The future is going to be really exciting. We're going to be looking at even more task shifting to community health workers and to families at the same time as we're making moral cases for specialist care at facilities. And really, I just want to land with a quick stat and maybe a reframing that I hear this statistic a lot. There are 1 billion people who will never see a health professional in their entire lives. They'll go their whole lives without seeing a doctor or a nurse or clinical officer. So I think this room is tasked with doing is basically constantly reimagining how we achieve equitable outcomes. And to do it with tools and infrastructures, technologies and people, the 10 million community health workers worldwide, the 6 billion mobile connections, to see what we can do now. So I'm excited to engage with you all. Thanks for having me.
We do have a few minutes here for Q&A. Thank you so much. That was just really amazing. I have some questions, but in the interest of time, if you have questions, I want to get those out here. So would anybody like to stand or shout and offer some questions for the panelists? And if you could, you can direct it to a panelist or all panelists, and then we'll... Hi, how are you? Thanks.
Hi, I'm
What's your
good.
question?
I'm Kathy Kim. I'm a researcher at San Francisco State University, and I appreciated everyone's comments. We're starting a project with 3 Native American tribes at the California-Oregon border where there's no cell phone coverage and no broadband access for almost anybody. What do we do for them?
So I'll start. So it's really tough in the U.S. I'm going to give you a quick anecdote from Liberia and DRC, where we're actually standing up our own cell tower using an open source GSM stack called OpenBTS. It's provided by Range Networks in San Francisco, costs about $25,000, and it'll cover about 40 kilometers in each direction. So I wish we were in a different regulatory environment in the U.S., but we're not quite there. So maybe Joe has a more practical answer, but...
Well, I was just going to say that in places like Zimbabwe and other places where there's limited, or villages where there have been limited penetration, obviously that's one solution. But the other thing that we found, and we found it in the United States building the Dean campaign, is that there's somebody who has cell, and there's some person who's got a laptop that's connected to the internet. Maybe very, very few. But what we found was building information bulletin boards off those people. In other words, they became the leaders of the movement. I'll give you a story. In Austin, Texas, we had, I think it was something like 100 people who were for Howard Dean at the time. That's all we had. We emailed all 100 of them saying he was coming. What we didn't realize was that two of those 100 people said, if he's coming, we should get everybody together at a meeting at our house to spread the word that he's coming. Those 2 people put out the word that they were holding a meeting. 100 people came to the meeting. We'd only sent 100 emails out. When we showed up at the park, there were 3,800 people in that park. And what had happened was those 2 people, we know this because we had clipboards and we had people sign up and we asked them for their email, thinking because we were the big tech campaign. No one there had email. They were all like, left a phone number or an address. They didn't have email. What these guys had decided to do is to leaflet the entire barrio of Austin, Texas. They thought that was the place that more people would be interested that he was coming. None of them had computers. I mean, in the neighborhoods that they were walking, no one had computers, but they came. And so what you have to do is build a system, I think, that that acknowledges that, hey, we're not going to some place, we're not operating a place where 100% have it. But if 5% have it, and we can get them engaged to spread this health information or to become part of the information hub, even if it's to collect cards with questions that we can then answer and get in a two-way with them, or just set up a kiosk. That's the other thing we've done, set up a kiosk in the area where people can, one connection, get, so there's ways to do it, but there is sort of an entrepreneurial build-it-yourself quality to it.
Well, and I also want to remind all of us that in the good old days, mHealth research was done with those dinosaur things called PDAs, and a lot of very good ecological momentary assessment work was done on devices that had no connection to the internet. And this may be a context where something like that turns out. Now, I think you could actually build something more sophisticated than what folks like Dr. Adi Atienza in the back there did in the early EMA days. But functionally, there's a lot you can do with electronic capture, data capture, that doesn't really require to be connected.
Can I offer a comment too? Josh said something a couple years ago that's always stuck with me, which is there will be a day, which we don't call it mobile health, we just call it health.
Health, yeah.
And I wonder if your patient population doesn't have access to towers, if mobile health is the right intervention. Or maybe there's a Sunday church service where everybody goes and you set up a table outside.
Radio.
So I would think that through.
Josh, could you expand on that comment?
I was just one word, radio, and both broadcast and high frequency for some data transfer. I'm happy to put you in touch with some folks.
Yes.
Michael Sanchez from the National Cancer Institute. I was really intrigued by the last two presenters in the way that you used mHealth as an engagement strategy to get the end user to basically use the intervention more frequently. But there were two very different approaches. One was targeted at the individual engagement. The other was at the community health worker engagement. And so with the Affordable Care Act, there are provisions to increase the number of community health workers with the idea to serve the underserved community. So I'm wondering how do you make these decisions about which type of engagement is more appropriate for which community?
Go.
So as an example of a blended approach, in that trial in India that's now scaling to 4 other states, it's actually engaging both the community health worker and the household caregivers. We have other projects where it's patients and community health workers. Basically, what you need is a chain of actions, a chain of human behaviors, and really deeply understanding how your messaging or how your app or how your thing or how your change fits into that chain of behaviors that takes you from the current chain of events to a new chain of events in a very replicable fashion. And the more replicable, the better. And so it's more about good design than it is about targeting one particular type of user across the board. And I'm always up for a brainstorm.
And so similarly within, in particular, the Smokefree Teen project, it makes sense to really think about what's the target of that particular resource and what's the functionality. So we have recently engaged in a partnership with Health Corps, which is Dr. Oz's charity group that focuses on cardiac health within schools, mostly because I really want to meet Dr. Oz. Although it turns out he's got some advantages to his network does. And so what we're doing with them is we're actually designing 2 different resources. One resource is targeted to what are functionally the healthcare workers within his program to assist them in understanding certain kinds of educational and intervention approaches. And the other is a resource that's targeted to the teens. And so, again, this kind of fits that blended approach that Josh was just talking about.
Do I have space for a quick comment?
Absolutely.
Okay, so quick comment here. It's my favorite quote that I've heard in the last month. It's from the Minister of Health in Liberia, Dr. G, who we were having this big discussion about the global health workforce and the shortage in health workers and how we need more health workers. And he said, whoa, let's wait a second. I want to propose a new definition of a health worker. A health worker is anyone in a group of people working together to solve a problem. So that includes the home-based caregiver who's cleaning bed sheets during palliative care, the community health worker who's bicycling a sick patient in, the mom of kids, the kids if they're behaving and active in their health, right? So yeah, it's really, that's what mobile does, is it frees us from facility-based care and other sort of traditional definitions and lets us focus on achieving outcomes together, which is really exciting, I think.
Absolutely. Yeah. Hi, yes.
Hi, my name is Ruth Gersinger. I'm a nursing student at Johns Hopkins and a former marketing manager in mobile video games. And I'm curious to hear if you have any experience in video with mobile and reaching populations, and specifically any kind of, any successes or just any information or research you could share about that.
Have you done any of that, Joe, in campaigns?
Well, yeah, in campaigns, we're using it all the time, but our experience in Africa, in terms of reaching under penetrated areas, and it's still, you don't have the capacity yet to shoot video over a lot of mobile. Look at the phones that you're working on. I never, imagine you could do that stuff with those phones. So I think it's happening and will happen, but again, part of this is, again, how rapid the technology is moving. That will be there very shortly. The ability will be there. So that kind of experience is going to be very, very important, because where we have seen it used, it's obviously video. You can send it straight to the woman in the right age group and engage it, and it can be, whether it's gaming for a younger person or some other way, a way that reaches them where they are. But the problem is the systems are not quite up in a lot of these countries to do that yet, or even in the on the reservation, or some of the places that we're trying to reach that are underserved.
So we are getting the hook here, but before we go, we want to have our panelists each tell us to do two things. And Josh, since it's your idea, we're going to start with you. To share something socially, and then to do something. So can you take it away?
Yeah, so I'll combine those. What I would love to see happen is that the global cancer community basically gives technologists some marching orders. So just like maternal and child health, HIV, AIDS, and malaria are pulling technologists and setting six-month goals and 5-year goals, I want those same challenges from the global cancer community articulated really clearly to technologists. So that would be great. 6-month goals and 5-year goals. Both would be awesome.
So what I would like to have people share via all your Twitter accounts and these things is that we need to have a real focus on tools, not toys. So this idea that it's very easy to get distracted by the sparkly new technology, but fundamentally you need to very carefully think through what is the role of that piece of technology in whatever your program is. So that would be what I would have you share. And then my challenge to you, which is a follow-up on that, is in the next 6 months, rather than focusing on developing a new resource, focus on taking the resource your organization is already using and make it better. Focus on these questions of how do we change the interactivity of this tool such that it increases engagement.
Thank you. From an academic's perspective, I would like to see more collaboration between the suppliers and the academic communities so that appropriate baselines are taken, so that we have some evidence from implemented technologies about what difference they're making, if at all.
I'd just like to sort of have everybody share or promote out there that the mobile phone companies need to let go and let us use their networks for help. To get to the point of where, they ought to be doing this as a public service. We should start, you should demand it. On your Twitter accounts, start to spread the word that we should demand that they have the privilege of charging people and making all this money by having those towers up and off the commerce, they should, like TV stations in the States, have to provide a public service, and the public service should be no fees for this kind of for these kind of messaging, and to open up their SIM cards. So I think creating that kind of, if that's what you leave here today and can tweet something about that, that would be cool.
I will clap for that.
Thank you for being here.